My name is Janelle Simmons, and I'm the Manager of Programs at Sigma Xi, the Scientific Research Honor Society. And I'm honored to introduce you and welcome you to our second presentation on our series on COVID-19, which is sponsored by our Committee on Lectureship. I would like to introduce to you our moderator, Dr. KiKi Sanford, who is the VP of Public Relations at Science Talk and is also the owner of Broader Impacts Productions. She is a freelance science presenter and reporter who loves media. She studied molecular, cellular, and integrative physiology. So she's a neurophysiologist and has over 10 years experience producing and hosting radio and television programming with companies such as WNBC, PLOS1, and the Science Channel Discovery Communications. And she currently hosts This Week in Science podcast. So thank you, Dr. KiKi, for serving as our moderator. She is based out of Portland, Oregon, and our thoughts and prayers are with those in Southern Oregon and also in Northern California who are currently being impacted by those fires. So we are thinking of you, Dr. KiKi, and everyone in those areas. So Dr. KiKi, the floor is all yours.
Great. Thank you so much, Janelle. And Iman, thank you for the introduction and for inviting me to come moderate today for this event. I want to welcome everyone to this conversation with Dr. Michael Osterholm for the Sigma Xi Distinguished Lectureship Series on the evolving reality of COVID-19 and the pandemic. If you have questions, please ask them in the Q&A panel for the Zoom interface, and I will try to get to as many of the questions as possible in the last 20 minutes of the hour. I'd like to introduce our speaker for the day. Dr. Michael Osterholm is a professor of public health and the director of the Center for Infectious Disease Research and Policy at the University of Minnesota. He has spent his career working in epidemiology, pandemics, and health security. And as a leading voice on science and public health throughout this pandemic and in the many years prior, I hope that he doesn't need much more of an introduction than that today, because I just want to get to our conversation. So thank you for being here today, Dr. Osterholm.
Thank you. It's my honor to be here. And actually, as a Sigma Xi member, and having been inducted at my undergraduate college, Luther College in Decorah, I want to shout out to all of my colleagues there and to say what a great honor it is for me to be with you today. So thank you very much.
Since the topic is the evolving reality of the COVID-19 pandemic, and many people have come to talking about their lives in terms of what they are like now and what they were like in the before times, how has your life changed since the pandemic began?
Oh, in a number of ways. Let me just take some of the obvious ones. I was, until March of this year, a 200,000-mile-a-year air flyer around the world. I have not been on a plane since early March. Like many, I have experienced the sequestering at home to protect myself and my loved ones from contracting this virus infection while still leading a team of people who work at the University of Minnesota, also in distance settings. I've experienced all the emotional issues that others have. Where we were in January to where we are now. Our group was one of, I think, the very first in the country to really call out the potential for this to be a pandemic. We actually published a document on January 20th saying this was going to be a global pandemic. Let's get ready. I published a piece in the New York Times in February calling out the same issue, that we needed to get ready for a pandemic. So for us, we've been seeing this for a long time. And realized in many ways we're still at some of the earliest days, not the last days of this pandemic. And I think that's something that's hard for people to understand. So from that standpoint, I think it's really a point of understanding where we're at in this journey and being prepared that we have to go a lot further than we are right now. And not being prepared for that is only going to make it more difficult.
So you just mentioned that you were one of the early parties who was really concerned about this pandemic. What what was it about the factors that you were seeing in January, December, happening in China that really made you concerned and think this is going to be the thing we've all been worried about for so long?
Yeah. Well, our group had been following this activity in Wuhan, China, in the last week of December, when it really first made the social media and made some evidence of being out there. And I've had an intense interest in coronavirus infections. I was quite involved with the US government response here in 2003 when SARS actually happened. I have been very actively involved with MERS epidemics on the Arabian Peninsula, serving as an advisor to the royal family of the UAE. I've been on the Arabian Peninsula working on these, and I also was brought in to help Samsung Medical Center in Seoul, Korea, when they had a very large outbreak in Korea in 2015 from a returning passenger coming from the Arabian Peninsula back to Seoul. So I've really, you might say, had more than a passing interest in coronaviruses.
Yeah.
And what was really very clear to us in the beginning was when this was shown to be a coronavirus infection, and January 10th, the Chinese did publish that information, is that it was unlike SARS and MERS in that the vast majority of transmission with those two viruses occurred usually 5 or 6 days into an individual's illness. And that if you could identify those cases quickly enough, you could isolate them and really stop any additional transmission. Here, there was clear and compelling evidence of person-to-person transmission that was occurring well before people were clinically ill, if clinically ill at all. And we already saw cases beginning to move out of China even by January 20th when we put our statement out. So it had all the ingredients of being a respiratory transmitted infectious agent that asymptomatic people could transmit, or at least early in their clinical illness, and that it was a very severe disease. When you put that all together, for me, you didn't need to understand that, what was yet to come was not going to stay just in China, that it was going to go around the world.
Has it played out the way that you expected it to?
I think there are several things. One is the fact that none of us really knew how to interpret an unfolding coronavirus pandemic. We all were really preparing for influenza as a pandemic virus. And with that, we know we get waves. We see a first wave that cases peak typically within 4 to 8 weeks of its appearance. And then for reasons that have nothing to do with human intervention, case numbers drop precipitously, kind of forming a trough, and then will often come back some 2 to 3 months after that. And often the second big wave is the one that really has major impact. If you look at the last 10 influenza pandemics over the past 250 years, 2 started in the winter, 3 started in the spring, 2 in the summer, and 3 in the fall. Every one of them went through that same pattern. People may recall as recently as 2009 with H1N1, there we saw cases begin to show up in Mexico in mid-March. Cases peaked out late April, early May, dropped off through early part of the summer, and then came back with a huge second wave in late August through early October, well before vaccine arrived. And so we thought, could this be how this pandemic will unfold? And we actually put a document out from our center laying out scenarios, not models, but scenarios that said one could be like flu, another one could just be where it's kind of a slow burn, and the other one could be like a forest fire. Well, it's turned out to be like a forest fire. There are no waves. This will burn wherever there is wood to burn, i.e. humans. And so this is really like a coronavirus super fire. When you see very few cases in a given area, it has nothing to do necessarily that the fire won't come there. It's that the behaviors, the activities, surely have not supported transmission, but that will change. A good example I give you was in March, April, we heard over and over again, well, California is not being impacted all that much, and look at what's happened in New York. It surely must be for some reason, i.e. probably they lack public transportation. People aren't getting infected on subways in LA, et cetera. Well, then look what happened by July. California was on fire. And this is actually what happens with forest fires. They don't burn evenly. They don't burn everywhere all the time, but once they do ignite, they can take off. So I think that might have been a surprise, you would say. I would say it's more we just didn't know initially. And so today, this is just going to keep burning wherever it's not being suppressed. I think the second thing that you know, it would be hard to imagine this. I had the good fortune to know the late Tom Clancy, the author. And I remember one night at dinner, he looked at me and he said, you know, Mike, the only difference between reality and fiction is that fiction has to make sense. And, you know, I think he's right. In this case, if you had tried to paint the political aspects of a pandemic on top of the very serious, challenging public health aspects and mix that into an entire global politic, you would never necessarily have thought that this would all happen. So I think that's the other surprise. The final one, which I have to say I'm still waiting for, is how will we have an exit strategy here? And I'm sure we'll talk about that. Will we develop vaccines that have durable immunity? Will we see people getting reinfected over and over again with this virus? How long will it take to get vaccine out? Once we have it, how well it works? So I think those questions yet to be answered will really determine how the rest of this plays out. And I think right now it's way too early to tell.
Are aspects like the asymptomatic nature of this particular coronavirus part of why we weren't really prepared for this pandemic? You wrote a book in which you laid out 9 steps to strategically be ready for the influenza pandemic, right? So where were we? Why were we not prepared? We saw SARS, we saw MERS. We've seen the coronaviruses. We've seen these little inflagrations, but we weren't ready for a coronavirus. We were just waiting for the flu. What happened?
You know, we weren't, even though we had a condition called disease X we were preparing for, you know, where we did acknowledge that if it weren't flu, what might it be? But a good example of the point you make, and I think, Kim, you really were right on the mark with this, is testing. You know, when we have a flu pandemic, we're going to make the assumption, or we had, that once we confirm people have flu, we won't keep testing everybody. Because once they're clinically ill, they have influenza, and we wouldn't have thought of a large asymptomatic infected population transmitting it. We wouldn't have thought of this kind of reservoir of transmission that we weren't seeing in terms of clinical cases. And so there wasn't really much emphasis placed on testing infrastructure or how to move it quickly. And so when this came along, where, as you pointed out, the asymptomatic infections play a key role, and that to understand transmission, we had to infect, you know who was infected, not just who was clinically ill. And we had no infrastructure, private sector-wise or government-wise, to develop the kind of testing capacity we needed and implement that on a nationwide basis. Other countries were better prepared for that and did do a much better job. We're still way behind the 8 ball on the testing issue and what we need to do and how to respond to that. So that was surely an impact that carried over from flu planning, was the lack of testing support, which has made it a big challenge.
We've got governmental initiatives like Operation Warp Speed, and there are other international initiatives, efforts that are increasing the funding and the speed of research at which we're finding out about this virus and developing a vaccine. Do you think the speed that we have achieved of this gathering of scientific knowledge is sufficient?
Well, a couple of things there, that one which is in our control and one which is not. The development of these vaccines, multiple vaccine platforms, multiple vaccines, both in the US and elsewhere, is simply a remarkable accomplishment. You know, the fact that we're, sitting here 7.5 months out from discovery of a new agent, and in some cases with vaccines, we've never actually had the platforms available before that we're now using to deliver these vaccines. And with the fact that we have as much going on as we do is a real testament to the R&D capacity of the world. I give everyone great credit for that. I think the challenge with that is that people are still yet skeptical. Have we taken steps that skipped over very important considerations about safety, about how well the vaccines work? And I'm quite confident at this point we haven't. I think that we learned to rather do things in sequence. They did them simultaneously at great cost. By the way, these are costly things to do. We're creating millions of doses of vaccines that may never get used if they don't get approved, but we want them available at the moment that a vaccine might get approved, if in fact it does. That's expensive. So I would say that in that regard, I think Operation Warp Speed, I think what the Europeans are doing, I mean, we're still learning a lot more about the Chinese and the Russian vaccines, but I'm optimistic that everything that could be done is being done. Now, the next question, though, is does that mean that we're going to have safe and effective vaccines in the near term? And I think that's what we don't know yet. And I say that for two reasons. One is that you can't study the safety of a vaccine for 3 years when you're in the middle of a pandemic wanting that vaccine today, because 1,000 people a day are dying right now. You know, every day we don't have the vaccine is another day we lose lots of people. So there's a natural tension there. We want these vaccines as soon as possible. Are we going to wait 3 years like it might be if it were a standard vaccine that would take 7 to 10 years of development before it were licensed to find out whether or not you still have protection 2 years out after the vaccination? No, we're not going to wait. If there are long-term safety issues, which, you know, at this point, we don't have reason to think that there will be, but could there be an antibody-dependent enhancement type reaction that occurs 2 years from now if I get infected with the natural virus and having this low-level antibody production? We don't know that. And I think that in that regard, that's a challenge because the public's going to want an absolute guarantee of safety. We have to say, in the first 6 months of using this vaccine in research protocols, this is what happened or didn't happen in terms of protection and safety. So I think that that's where we're going to be with the vaccine going forward. And my concern is that we've now interjected the politics of vaccine approval into this, which has made for an incredibly complicated and even toxic experience. And the reason I say that is because just today, an article published by the commissioner of the FDA and the senior leadership there boggles my mind that they have to publish an article saying that they're going to hold to the science for these vaccines. Yeah. I mean, I would never have imagined that being necessary for a vaccine to be successful in the public acceptance. But yet, on the other hand, a survey data that came out today also shows that 63% of Americans either won't take the vaccine or are highly skeptical of the safety of this vaccine or vaccines. So we're in a very tough spot to make sure that we don't have a vaccine approved for reasons other than the science before the election. At the same time, we also know that these vaccines are desperately needed. We need to get them out. How do we convince the public, where anti-vaccination activities are already ongoing, that it is the vaccine you should take? It will have a difference, make a difference. And so I think that's the challenge. The final piece I would just add on the vaccine thing, which is, you know, kind of all of our collective worries, is just how long will these vaccines last? Meaning that if you do get vaccinated, because we know we're seeing reinfections already. We're seeing individuals who were infected early in the pandemic who now 2 and 3 months later, 4 months later, are breaking through with second infections. And there's only been 8 of these documented so far. And you say, well, that's hardly anything. But that's also because to be actually documented to have had reinfection means you had to have a virus isolate with the first infection and one with the second infection, which almost no one out of the millions and millions of cases ever has done. So it could be that reinfection is more common than we realize, which says you don't get durable immunity necessarily. And if we don't get durable immunity, that adds a whole new complexity to the vaccine picture.
Yeah, my 8-year-old just this morning commented on how it would hurt to get another shot, but he's ready to get another shot every year if he has to, like for the flu.
Good mothering. Congratulations.
Yeah. So people are already thinking about this. You know, and I don't know, would you say, I mean, there's the idea for product design that you can do it good, you can do it fast, or you can do it cheap. And in the case of the vaccine, we're doing it good and we're doing it fast because we're spending a lot of money on it. Yep. So it's going to be good and it's going to hopefully be fast.
Yeah, I think you've nailed it. I think that we are paying a premium for trying to buy down the, you know, what we can in terms of vaccine production now. I mean, what people don't understand, I think, is that even if a vaccine or vaccines are approved yet this year, you know, between now and December or early next year, it will take months and months to actually manufacture enough vaccine for everyone in this country to get what will likely be a 2-dose regimen. And so that this isn't going to end overnight. I mean, we're still talking about as much time that has passed since this virus first appeared before we might see a substantial number of Americans have access to vaccine. Now, it seems like it's been a decade or more since this virus first appeared to many of us. And so to anticipate that we are going to have a lot longer road to hoe, I think is really a challenge, but it's where we have to go. So yeah, the vaccine, I think, is coming as quickly as it can at a great cost. And again, I just can hope that the vaccines are going to be really effective, not just for a couple of days or a couple of weeks or a couple of months, but for years and years. And obviously, we wanted to protect as many people as possible, which we still don't know what those answers are to that very question.
In terms of other ways to protect people, I mean, the vaccine, people are really hoping that it's going to be the, you know, the silver pill, the thing that fixes everything and everything can go back to normal. But in the meantime, as you're alluding to, this is going to potentially take a while. It may not be, probably won't be November, may not be January 2021. It may be next summer. It may even be beyond that, that we have a vaccine. How can we continue to protect ourselves and others? What are the proven ways that we know of right now?
Well, that is the trillion-dollar question. And let me put it in some context. When we look at what's happened in the United States to date, our best data as of today suggests that between 10 and 12% of the US population has been infected already, which many of those will obviously have some immunity. As I already pointed out, some may be losing it already. But to actually develop what we call herd immunity, the concept of enough people in the community having become immune, either through vaccination or through natural illness, that they're like rods in the virus transmission reaction. So that, you know, if I can't transmit to at least 1+ people, then the virus is going to die out. If I transmit to only 7.7% or 0.7 people, then, you know, over time, you're going to see the pandemic die out in that area. And so one of the challenges we have with herd immunity is with this virus, our best guesstimate is it's going to take 50 to 70% of the population to be immune before we start to see herd immunity kick in. And even then, herd immunity is not like a light switch on and off. It's more like when you hear the old days, that pilot saying, okay, we're now beginning our descent into LaGuardia Airport. We'll be on the ground in 30 minutes. What will happen is if we get to 50 to 70%, that's when we see transmission slow down. And we've had some really remarkable experiences with that in the last several months. For example, in our prisons, where we've seen as high as 80 to 90% of the population getting infected, transmission didn't slow down until it got to that 60 to 70% level. So we have to, first of all, understand we have a lot more human wood to burn in this coronavirus forest fire. And transmission will continue. You know, we've been predicting from our group for the last 2 months that the fall was going to be a real challenge for several reasons. Number one is that when students came back to colleges, universities, and high schools, the older adolescents, younger adults, we're going to see an explosion of transmission. Well, it arrived right on time. And I think over the course of the next 6 to 12 weeks, we're going to see very substantial transmission in that population, which will spill over into those in the population that are potentially older, have underlying health concerns, and it'll be an amplifying event that will keep case numbers substantially increased. I think we're going to see more rounds of outbreaks in long-term care facilities as a result of that spillover, et cetera. But then in addition, one of the really quote unquote toxic situations with this virus in terms of transmission is indoor air. We know that that's where a lot of virus transmission can occur. That's where most of the super spreading events occur. It's the lack of ventilation and circulation. And as we get into our fall and into early winter, and you know, people are going to be inside, crowded areas will probably likely occur again, and we're going to see substantial transmission. Remember when we really were a house on fire this spring, we were in that late March, early April, going into May time period when we were coming out of our heating season. So this will be our first heating season indoors that we've had for much of North America, and that's true for much of the world. So it's going to be a challenge between the amplification of virus from schools, colleges, universities, and indoor air. I think we could have a really tough fall.
Could we or can we look at data from the Southern Hemisphere who are coming out of their heating season and apply what we learned there to the Northern Hemisphere?
Yes, we can. The challenge with that is we don't have that large of a population base as there. If we look at countries like South Africa, they've been hit hard. They've been hit really hard. So here they were in the wintertime hit hard. And this again is another one of those examples. In the early days of the pandemic, I saw so many papers come out that frankly were academic googly gook. Somebody basically put out, well, this will only affect between this latitude and that latitude because that's where we've seen the major houses on fire. Well, and in a sense, it was just a matter of time and travel as to where it got around the world. If I heard once, I heard 100 times, well, India is doing something right because for the first 4 months of the pandemic, we saw almost no activity in India. Today, they're about to overtake the United States as the most impacted country in the world. And so I think that one of the challenges we've had is interpreting country to country. If you look at two areas that we've often followed for influenza is New Zealand and Australia, you've seen that as being island states, they surely have some advantage in trying to slow down transmission. Even New Zealand, which had once declared itself virus-free, had another resurgence of activity as it somehow got into the country. They've now pretty much, it looks like, got it kind of under control again. But look at what's happening in Australia. In Melbourne, areas of southern Australia, they've actually been in lockdown because what they thought they had controlled there came back. And so I think that, and if you look in Africa, I just have to say that one of the challenges in Africa is just the absence of testing in so many locations. I've worked closely with the African CDC and other organizations in Africa, and the absence of evidence is not evidence of absence. And I think that we have a lot more going on in Africa that we just haven't picked up. So I think from a standpoint for what might this portend for the Northern Hemisphere's winter, I think is not good. Also, we have influenza we have to deal with. Now we've seen a substantial reduction in influenza in the Southern Hemisphere compared to any previous year in recent memory. The challenge with that is I don't know if it has to do with the kinds of steps we've taken to reduce COVID transmission. I say that because in countries like New Zealand and Australia, before they saw a resurgence of cases, they weren't doing a lot of the mandatory activity they are now. We still didn't see influenza transmission in June and July of this year, which would be their flu season, their winter. And so, if you've seen one flu season, you've seen one flu season. I don't know what's going on, but that's the challenge we have right now.
Is there anything that we can specifically do? We've got these epidemiological terms, R naught, IFR, CFR, these numbers that have become more public knowledge that the public wasn't initially aware of, that now people are throwing around like confetti on Twitter. Can you talk about what we know about these numbers and how we can potentially address reducing them?
Yeah, and then, thank you. This is a very important point because they get used a lot. I've been in this business 45 years. I've worked on a lot of infectious disease outbreaks and, published a lot. And I have to tell you, sometimes I am baffled by how much importance is placed on some of these. And what I mean, not so much that they're not important, but the precision which people are trying to measure something is actually quite imprecise. Let me give you an example. If one looks at the fatality rates, trying to understand, what percentage of people who get infected die, and you can determine how you want to call that, IFR or whatever, okay? Take a country like Korea. Early on, they were being touted as a country, they're doing something right. Their case fatality rates are really, really low. And look at ours. Well, when you looked at who was getting infected early on in South Korea, it was largely part of a religious sect. Many thousands where the median age was 38 years old. And so, of course, you would expect to see, just based on what we know for risk factors here, to see a lower case fatality rate. As soon as this got into older populations in Korea, numbers jumped right up, just like us. And where we had outbreaks early on in congregate living environments or congregate working areas, particularly in long-term care, we saw astronomically high numbers of deaths. Whether or not you provide care in your home or in a long-term care facility. In Asia, many of the older individuals in their society are cared for by their family in their homes. And so you didn't have these large, quote unquote, nursing home outbreaks in Asia that you would have here. So none of these have to do with somehow the virus acting differently in different countries. It's all about which populations were most exposed first that would then result in the potential difference. A good example in this country is if you look at in China, the rate of obesity in those over age 30 is extremely, extremely rare. If you look at those under 30, it's not so rare in China now. But if you look in this country and look at obesity starting in the teen years, it's much, much higher. So if you took two populations otherwise absolutely the same in age distribution as in China and here, and then try to compare what might be case fatality rates, it'd be totally different just by the underlying risk factors that are there already. And so I always had a bit of a challenge trying to parse out what's this doing or not doing. But let me just add context to this, I think. An event that I hoped I would never see in my lifetime, and I hope I don't see it again. And that is on March 1st of this year, COVID-19 was not in the top 100 causes of death in this country, not in the top 100. By April 20th, it had become the #1 cause of death daily for weeks. We had not seen that since 1918. That's the last time we saw that happen, 1918. Now, grant you, the intensive care medical community has done a remarkable job at better treating these patients, understanding without even new drugs, mechanical ventilation, issues around dealing with immune suppression and the whole immunologic response. They've really improved the care in a real significant way. So we clearly have seen the case fatality rates come down. In addition, of course, remdesivir, which is now available, may have had some marginal impacts. Steroids in general surely are having some impact. But so part of it is it's hard to compare the case fatality rates of today, even with April, just by what's happening there and that. But I come back to it in the end is I'm very concerned. Remember I talked about that 10 to 12% of the population infected. And if we're going to have to get to 50 or 70% to develop some aspects of herd immunity, again, that doesn't go away, it slows down. And vaccine's not a big part of that. For all the pain, suffering, misery, death, and economic disruption we've had, we have a hell of a lot more to go to get to 50 or 70%. So that's what we want to avoid. We don't want to have that happen. We're trying to keep infections low, at the same time, not just burying society into even more pain and misery financially or otherwise. And that's the challenge we have going forward.
Yes, it's a huge challenge moving forward. And I think wrapping people's minds around that is going to be an even bigger challenge. I feel like we've been moving forward kind of in these 2-week increments of what's going to happen 2 weeks from now, not really planning far into the future as to how we're going to respond. And like you said, we've seen that play out in what's happened with the opening of universities and schools around the country.
You nailed it right on the head. I think that's exactly it. And that's the challenge we have before us. I think your 2-week window is kind of exactly where I look at it from. Every 2 weeks, it could be a whole new COVID world at the way things are going.
Yeah. So when we think about where we were at the beginning of the pandemic, we didn't have enough PPE for healthcare workers. We didn't really know how to treat it, the low oxygen situation. And now we've come to a better place of treating it. Do you think that we are moving forward going to be better able to treat the really badly infected, the people who end up in intensive care, or even reduce the number of people who end up in intensive care before we even get a vaccine?
Yeah, let me kind of try and truncate that question into the high income countries. First of all, I think, yes, we're going to only get better We are continuing to see improvement in when you put people on mechanical ventilation, when you don't, how you monitor immunosuppression, whether that's a favorable or unfavorable approach. Any number of things like that we're doing a much better job with. And again, I salute the intensive care medicine doctors and nurses, support teams for what they've done. I mean, talk about being in a war. They've been there. Most people don't realize, but in the United States, over 1,000 healthcare workers have died from COVID-19 infection. Not all of those acquired on the job, but many were. And I can't say enough incredible compliments about what they've done. So I think we'll continue to see care get better. We have not yet had a knockout, oh my God, isn't that an amazing drug finding yet? We're still, remdesivir is at best marginally helpful, plasma marginally helpful, it looks like. Probably steroids may have more impact than any of those. And so we're still trying to do better there, but a lot of other parts of the medical approach have improved. What I worry about and continue to worry about is what we're seeing in so many countries of the world, where middle and low income countries, who will be the last to get vaccines, unfortunately, given I think the current scenario, are also the ones least capable of providing intensive care medicine. And so for the billions of people in those countries, the future outlook is not good. It's not good at all. And I think that's a challenge. We saw that in the Americas. If you look at what's happened in South America over the course of the last 10 weeks, it's been devastating, just devastating. And then the other thing that most people don't remember or talk about is collateral damage. As much as, everyone focused on Ebola in the DRC over the last couple of years, where we had an outbreak that was ongoing, of which several thousand cases, a number of deaths. What people don't realize, during that time, 3 times as many kids died from measles in those same areas because we couldn't deliver measles vaccine. And far outstripped Ebola, and yet nobody talked about that. We're beginning to see the collateral damage occur around the world of the lost opportunities for public health, for childhood immunizations, for maternal and child health, HIV/AIDS. I can go down the list, polio eradication. And so I think one of the yet unrecognized costs of this pandemic in terms of life and quality of life is well beyond that of just COVID-19 itself. It's also the issue of all the other public health challenges that are really in trouble right now.
And that's a huge debate, actually, in the public sphere. And if the outspoken people on social media are to be representative of the two sides of that debate, we have people who argue that the social costs to lockdowns and control methods to minimize the impact of COVID-19, of the SARS-CoV-2 virus, that it's not worth the loss of life on the other side. And there are other people who say this virus is, it's 10 times worse than the flu.
Yeah, yeah.
So we should be doing all these things. Where should we be talking about this controversy?
Well, this is where there's a tremendous amount of confusion and misinformation. Let me just take a step back and say that pretty much the whole world was a house on fire in March and April into early May. If you look at the European countries, look at the Lombardy region of Italy, look at Paris, look at London. I go through all the various areas that were heavily hit, as were the Asian countries. And what they did, as we attempted to do, was lockdown, a term that is a loose fitting term to a whole lot of different activities, but is doing anything to restrict people's contact with other people, really. And those countries that really locked down didn't complete that activity in terms of driving the virus levels down till well into June, early July. But many of those countries got their virus activity to less than 1 new case per 100,000 population per day. We, on the other hand, locked down about the same time, but we really didn't. In our own state of Minnesota, where we estimate that about 37% of our population are classified as essential workers, almost 75% were designated by the governor as being essential workers. So we really didn't shut down the economy all that much here. Okay, so then what happened was, we got to Memorial Day and we had gone from a high of 32,000 cases, house on fire, to 22,000 cases a day. And we said, well, we're done. Pandemic fatigue set in, the protests were occurring. It was the summertime, we wanted to all be together. And suddenly we saw what happened. We went from 22,000 cases to now 67,000 cases a day, which far dwarfed the whole number of cases we were having in April, and it seemed like we couldn't get any worse. And then during that time period, again, Texas, Georgia, Florida, Arizona, all basically started the numbers coming down because of the fact that there was so much attention. In Florida, up to a third of the ICUs were overfilled with patients, et cetera. But then again, we brought it down, but now we're at today we're going to be at the low 40s, 40,000 cases today, 1,000 deaths. And yet that's 8,000 more cases than we had in April when we were a house on fire, but we've kind of accepted it. And I'll tell you right now, the case number is going to go up substantially again in the fall, likely far surpassing 60,000 cases. So in a Northern Hemisphere / high income country basis, we're still not doing well at all. We're going to see a lot of cases and we're not prepared for that at all. We already are seeing a N95 shortage here in North America again. Right here, we have hospitals in the Twin Cities, Minneapolis, St. Paul that have less than 5 days of gloves on hand right now. Even with this somewhat quote unquote stall in cases, as it's been described by some. And so I think we are still really challenged to respond when these cases come back. And even though ICU care will be better, we still have every reason to believe we could substantially threaten ICU care availability. And let me just add one other point to that. One of the things we haven't talked about, but will ultimately be, I think, well determined, is that when we look at places that are on fire, whether they are the states like California, Arizona, Georgia, Florida, whether we look at what happened in New York, there are real opportunity costs that occur with taking these hospitals over as COVID hospitals. And when you look at the mortality data from several of these locations, particularly New York, it was clear that a lot of extra people were dying, not just of COVID, but because of COVID, meaning that heart attack victims, stroke patients, people who had other major health problems couldn't get in or refused to go into a hospital because of the fear of COVID, and they died at home. And so ultimately we're going to have the direct mortality and we're going to have the indirect mortality. Now, and again, you get to middle and low income countries, they're not going to have the care, they're not going to have the PPE. If we think we have a problem with PPE right now, personal protective equipment, I can tell you there's much worse there. And so we are going into this next phase of this pandemic. And I wish I could say that we had done a much better job preparing. We haven't. It's a real challenge.
Okay, so on that note, everyone be ready to stay home. Limit your contact.
It's not so much, I think, Kim, and I didn't really answer the question. It's not about staying home. 3 weeks ago, Neil Kashkari, who is the president of the Minneapolis Federal Reserve Bank, and I had an op-ed piece in the New York Times in which we basically called for another lockdown. But this time on a regional basis or where it was necessary. New York doesn't need it right now. It doesn't. Right. And everybody said, oh my God, we can't do this. How can you say this? But ours came with a full financial reimbursement for loss, whether it's wages, small, medium-sized businesses, restaurants, bars, cities, counties. It turns out that our savings rate in this country has gone from 8% to 22% over the course of this pandemic. We could finance all of this debt out of US dollars, paying back interest to US residents. And the Federal Reserve has actually modeled this and said, the economy is going to do much, much better if we get it done and move on and bring this under control and then get people back into public spaces, not afraid to be there, getting schools open. But if we keep dragging it out like this, where we're now at 40, 50,000 cases a day, people are, and particularly those who are older at least, afraid to go back into public places. We're not being functional. We're going to have a hard time keeping schools open. And so our whole point was hold everyone harmless. Financially, you should be covered. No one should take a hit. And number two is the fact that what we can do by getting the numbers way down, we can open up. Look at New York. New York has been a model. I know that New York City is not back to where it once was. Everybody knows that. We're just now opening restaurants back to 25%. But they have been flat lined for the last 14 weeks. They've gone days with no deaths in the whole state. And they have done it really, really well to try to get us to that point one day of having vaccine without destroying the economy, but at the same time, not having to live with a 24/7 sirens in your ear because of what was happening in the community.
Yeah, I think that makes a lot of sense to look at things on a regional level and from the perspective of where the virus is really having a negative effect. And if it is, let's shut it down. But if you're in an area where it's not, you can open up. You can go
Couldn't
back
agree
to more
more.
normal.
That's exactly what we need. You again, you hit it right on the head. That's it. Yeah.
So we've got some questions from our audience who we cannot see, and we thank you so much for being here for this conversation. So Brian Dunleavy asked, is the initial viral dose related to the severity of COVID cases? And is there a known cumulative impact of repeated exposures to COVID?
Well, our group actually happens to be doing a lot of work on infectious dose, working with a group of individuals around the world on animal model studies, industrial hygiene modeling, aerobiology, et cetera. And at this point, let me just say that by far the best data we have, particularly from animal models, suggests that dose is not nearly as important as people thought as it relates to yes or no. And what I mean, I'll come back to that in a minute. Once you hit a minimal dose, it doesn't necessarily mean that more of it's going to make you more ill and less of it's not. It's all about the host and the virus. Let me just give you kind of a rough detailed idea. If you take a young healthy macaque and a monkey, which is the good model we're using today, and you take an older one, 12 years old, diabetes, overweight, and you give them both low dose of virus, the young macaque often shows very little, any symptoms, although they will get infected. The older macaques will get critically ill and potentially die. If you take high dose and hit both of them, the older one has the same thing all over again. The younger one now, more of them become more seriously ill. So there is a dose effect a bit there, but not to the extent that we see the big impact really being the host. So that's why you see so many young people who aren't getting seriously ill, or in that case, even recognizing more than a fever, a headache, chills, unless you have a risk factor. If you're 22 and your BMI is 38, you know what? You have a potential real chance of dying if you get this infection. On the other hand, if you're healthy, not. And if you get older and you have underlying health disease, kidney disease, cardiovascular disease, etc., your percentage likelihood it goes up substantially of having a serious outcome. So it is a combination in a sense of dose and underlying risk factors, but underlying risk factors are by far the really big factor. And that's why when we look at kids today, we have so many hundreds of thousands of kids that have been infected. And yet when you actually look at the outcomes, and any death is a tragedy. But we're talking in the United States today, still fewer deaths from COVID-19 in young kids than we'd expect to see in an average flu season, deaths there. That doesn't make them right or doesn't make it okay. It's just pointing out that it is different in young kids, and we still don't understand completely why that's the case.
From Roy Wools, I don't know if I'm getting the whole name here, from Roy Wools, and I think this follows on. Why don't we know more about asymptomatic people? And obviously the dose response to the viral load doesn't necessarily explain it. And are there things that we know that can explain why people are asymptomatic or not?
There's a lot of work going on that, and we just don't know. Both in terms of why they're not more likely to get clinically ill, but also how infectious are they and when. A lot of work trying to go on there. One of the problems with having asymptomatic people is how do you find them at the time they're asymptomatic and so that you can get them in and test them. And there have been some studies trying to get contacts of cases to enroll so that they can actually look more carefully and try to anticipate that. It's hard to get somebody coming into your study the day that they're going to become infectious but not ill. You know, how do they know it? And so that's been a challenge, but this is a really good question. We have a real need to understand asymptomatic infection, how much transmission occurs, when does it occur, and what that all means. So I would agree with you, and I think this is one of the priority areas we need to really continue to work on in terms of better understanding this infectious agent. Remember, it's going to be around for a long time, so it really is important we do understand this.
And his name was Roy Woolsey. Secondarily, what about vitamin D? We've been hearing links
there's been
to
lots
that.
of things put forward about zinc, vitamin D, et cetera. We've looked at these, and there just isn't any at all clear, compelling evidence that they make a difference. It was suggested if you just vaccinated people with childhood vaccines, it stimulates the immune system. Where that's been looked at, BCG, all of these, none of them have really panned out to show any benefit. I worry that we are focusing on kind of the hydroxychloroquine type approach where we have some anecdotal evidence from somebody who swears that 12 of his or her patients were saved because of this, taking this particular product, whatever. But we just don't have any compelling data. I mean, everyone would be willing to put whatever we could forward for research and development if there was even a simple sense that it was making a difference, and we just don't have that for these.
Can we talk for a moment about vaccine trials? We have a couple of different questions about vaccine trials. First, Matthew's asking, do any of the vaccine trials include seniors over age 65 in sufficient numbers? But I think to expand on that, it would be, are we collecting information on age groups sufficiently?
Yes, there is information on age groups. So far, the studies have avoided children, but they are enrolling older individuals right now. And I think you hit on a very important point. What are the numbers? That's what we're going to have to see. And remember, the numbers are important for two different reasons. One is how well does the virus protect? And of course, that's going to always be a function of where you're doing the studies at. If you're in a community that's a house on fire, you're going to have a much higher likelihood of hitting on that number of, how many placebo recipients versus how many cases get infected in the next 60 days. The second one, though, is safety. And the question we have is, how do you pick up a safety signal when something might be occurring 1 out of 50,000, 1 out of 100,000 people, which could add up if you're vaccinating, the world, but you're only having 30,000 people in your trial. What's that mean? And remember, that's placebo and vaccinees. So I think at this point, we will constantly be doing post-marketing studies all the time, trying to figure out if something happens to somebody who was vaccinated, what does that mean? Now remember also, it's obvious to this crowd, but health problems happen every day to people. That's why with these two recent events we've had with one of the vaccines, and as you know, AstraZeneca's vaccine is currently on a pause while they're evaluating a potential adverse event that occurred in one individual. Well, if you do enroll 30,000 people, you're going to have heart attacks. You're going to have people who are having any number of different things go wrong, just as if they were never vaccinated. And so the challenge is discerning which of the events are likely associated with the vaccine and which are not. Ironically, in the very first year of my career, I got very involved in Minnesota with a colleague documenting the occurrence of Guillain-Barré syndrome associated with the influenza vaccine, the 1976 swine flu vaccine campaign. And that was a very, a real learning experience for me in terms of having been involved with that. And so today we are many of the same pressures to get a vaccine out as quickly as possible, but also assure its safety. So we are going to have some challenges there yet. And we'll be learning a lot after these vaccines are given, and we just have to acknowledge that.
Can you comment briefly on testing? Christopher Rose asks, what is your stance on inexpensive, rapid, non-PCR home tests that could be affordably deployed?
Well, you know, it's interesting because somehow there again seems to be this for testing against testing kind of thing, which is not the case. Our group has written a lot on this. We have a document on our website called A Viewpoint. It's a overview on smart testing, having the right infrastructure in place for making a test with the right test given to the right person at the right time for the right result and the right outcome. And in many instances, the testing we've done in this country has had little impact in any of those. The challenge we have with testing today is not the theory of testing, it's the real life event. And what I mean by that is, you know, I'm happy to have people be tested. I'd encourage people to know and be tested. But if you look today, we have a third of the population in the US that doesn't really believe that this pandemic is real. They think it's a hoax. You've got an increasing number of people who are bubbled, who don't really need to be tested because they, in fact, are not being exposed. And then you've got groups like college students, where today we're seeing a very large number of young adults who are basically foregoing testing. They won't be tested. That's one of the problems we're having in college campuses right now. Up to 2/3 of them won't participate in testing or any kind of contact tracing. You know, having an available daily test for them is not going to help them. This morning I was on CBS Morning News, and the piece that ran along with me was actual footage from a college party where there were actually students who were willing to say on camera, yeah, I've tested positive this week. I have COVID. I don't give a damn. I'm here. And they were actually test positive this week, and they were at a party. And so, you know, part of it is the testing has to make a difference. It's the right outcome with the right test. And so one of the challenges we have is if you do use these rapid tests, don't expect the kind of big population impact that you think is going to happen, because many people have already taken themselves out of that potential category. The second thing is, and this is not by itself a criticism, in that if you do it enough times, you're right, you're going to pick it up. But many of these tests have sensitivities of 50 to 70% at most. Even the new Abbott Binox test, which has been touted as having 97% sensitivity, meaning that they tested 35 samples and got 34 of them right for their FDA submission. And knowing what the levels of virus activity were in those samples. They have a very similar test out for influenza, which has been touted as a great test. Right on the CDC website, it says don't use these tests. They're so ineffective at documenting someone's real infection status if they're clinically ill. So CDC says never use these tests for diagnosis. You have to use a PCR-based type technology. And so if you want to screen with them, fine. Just know that they're going to have some real problems with sensitivity. And then if they are in fact positive, what do you do then? Will people stay at home? Will they do their own contact tracing, et cetera? And we're finding more and more people that don't want to know that. If they're not clinically ill in a way that means they have to seek health care, you know, they're reluctant. And I don't want to sound jaded that Americans aren't going to respond, but I mean, we're seeing it front and center right now in a way that I could never have imagined in my career. It's a real challenge.
Yeah, it is a huge challenge. Pat wants to know how the world will likely look in 1 year. And I want to add to that, you know, people want to go on summer vacations next year. They canceled a lot of trips this year. What do you foresee? Your crystal ball.
Yeah. Well, first of all, let me just state the obvious. Like gravity, this virus is in control. We're not. At the best, we can impact how it affects us. But in the end, this is like gravity. It's here. And so I think the idea of what we do a year from now will depend on vaccine, how well it works, how many people are vaccinated, how many people will get vaccinated. You know, if we find that a large portion of the US population doesn't trust this vaccine, think about this. If it's a 50% effective vaccine, which I'm not saying it will be, but that's what FDA is willing to license right now, and only 50% of the population gets it, that means only a quarter of the US population will be protected against this, and 75% won't be. And they're going to be the people that will expose others. And even if I am vaccinated, what if I'm part of that 50% that didn't respond, but I don't know? Will I still go on that vacation? Will I still go on those crowded locations? So I got vaccinated. I'm sitting there going, geez, am I part of the ones that got protected or not? I don't know. I'm a little paranoid right now. Do I really like this vacation? Do I want to be here right now? I don't know. And so I think that we're going to have a lot of challenges working through this. And it's not going to be just straightforward and simple. And that's what I keep trying to tell people we need to prepare for. We are still early on in this pandemic. And people have to understand that, because that's what's going to help get us through, is doing the kind of preparation, the kind of work to help understand where we're really at.
And that is a wonderful message to end on. We have reached 12 o'clock. Thank you so much.
Thank you.
It's been just wonderful getting to speak with you. And everyone, thank you for joining us today. I hope that you join us again for another one of these distinguished lectureship series conversations.
Thanks, Kim.